So radioactive iodine is basically indicated as a second line therapy in somebody who has got a relapse or there is no response to methimazole or there is adverse effects. It should be avoided as discussed in active ophthalmology. If there is a one which is not very active, then in that case you can give steroids and do that. And if there is a large goiter, it is not contraindicated. It is not going to help you out because it is not going to damage that. And less than 5 years, don't use it at all. Aim is to cause hypothyroidism, ablation. It is not suppression, it is ablation, complete destruction. The protocol is that if somebody is T4 is high, in that setting, do not go with that. Start with an antithyroid drug. Stop for 3, 5, 7. A lot of people have different protocols. The dose, I'm sure Pratik will talk a bit more about that. There are two ways of going ahead. One is the per gram of thyroid tissue you calculate. The other is a standard dose which you use. And then there is dosimetry depending upon the thyroid weight and how much is the uptake. So this is the job basically of the nuclear medicine specialist. But remember, it should be the higher dose, not the lower dose. 5 to 10 years, lower dose is used in that setting. Now, the follow-up, of course, is that there are a lot of precautions which are there, which Pratik will talk about, which you have to be careful about, and beta blockers may be required in the initial phase. Once you do that, you start thyroid functions after 2 months, then 3 monthly. If there is hypothyroidism, start LT4. If there is a relapse, retreatment is started. Now, some of our patients have required up to 3 doses also, so it may be difficult. The theoretical malignancy risk is largely about thyroid cancer, which doesn't happen with the high doses which you're using, but less than 5 years, we have to be safe. Second malignancy, there is no evidence. High risk individuals basically are those who are less than 5 years and those who have a solitary nodule. So now Dr. Pratik will talk more in detail about the intricacies of radioactive iodine therapy.
To basically therapy, it is a therapy for common benign and malignant hyperthyroid conditions. Now, I-131 is a beta-emitting radionucleotide. It is administered orally in a solution or a capsule. And in this case, it takes around 6 to 18 weeks to show the proper response. So in thyrotoxicosis, it is given in where thyrotoxicosis is caused by Graves' disease, toxic adenoma, and multinodular goiter. So coming specifically to Graves' disease, the pediatric indications, the ATA 2016 says that Graves' disease, which is not in remission of about 1 to 2 years of methimazole therapy or thionamide therapy. But ETA guidelines is now, it does not mention RAI specifically, but for definitive treatment, if there's a relapse, if there's a side effect of ATDs or a poor compliance. Now, ATA guidelines also mentions certain indications that are not specific to pediatrics, such as women planning pregnancy in the future. That is after 6 months. If there is planning pregnancy within 6 months, there should be informed consent and you should avoid in those situations. If there are comorbidities, include increasing the surgical risk. If there's a previously irradiated neck or any history of any malignancy. If there's very important lack of access to high volume thyroid surgeons. If ATDs are contraindicated or there's been a failure of ATDs and periodic paralysis or CHF in elder individuals. Now coming to contraindications, absolute contraindication is a child under 5 years of age, current pregnancy, breastfeeding, moderate to severe orbitopathy, if there is suspicion or coexisting thyroid cancer, and who are not able to comply with the post-radiation safety guidelines. So as I mentioned before, any woman who's planning pregnancy within 4 to 6 months should have an informed caution regarding this. Coming to the relative contraindications, children between 5 to 10 years of age, inactive orbitopathy, where you can give with steroids, and a large goiter only because it might require repeated therapies. Now, one very important bit is a diagnostic dilemma. If any destructive form, such as any thyroiditis comes, few of these patients might have stimulatory antibody positive and might show increased uptake on the scan. So the only way to basically, most of them we are treating with MMIs, and if this patient is treated by some sort of ATDs, they will show rapid reduction in the thyroid levels. So in this case, we should not give radioactive iodine ablation before seeing which case of hyperthyroidism it is. So destructive forms, it is absolutely contraindicated. Now, what about the preparation before therapy? Beta adrenergic blockade should be done because there might be transient exacerbations. And it should be considered even in asymptomatic patients if any risk factors are present, such as any cardiac issues or other things. What about the methimazole pre-treatment? So they are advised to give methimazole pre-treatment to avoid any flare-ups after the treatment. So ATA mentions discontinuation of ATD for 2 to 3 days, whereas ETA now mentions thyroid association maintenance 3 to 7 days before therapy. Now, if risk factors for worsening of hypothyroidism present, they should be restarted after 3 to 7 days and then tapered from there. And of course, we have to rule out pregnancy before starting the therapy. Now, these were the guidelines given in ETA. Now, 3 important bits over here I would like to mention is to, before therapy, get an ultrasound done to see whether any other nodules or something are left around, or if it's Graves or not. Second is, as I mentioned, it is 3 to 7 days prior plan to I-131 therapy, you stop the ATDs. And one important risk is we should discuss the very small risk of thyroid crisis and what should be done in this. So patient be prepared if a thyroid crisis might occur.
I think one of the patients we discussed who had that periodic paralysis had a severe thyroid storm.
Okay.
FT4 was more than 100, I think.
Yes,
third one.
Second, yeah. So
Okay. Yes. After the second one. So what about the dosage? Now there are 3 approaches to the dosages. Either you give a fixed approach, 200 to 800 megabecquerel.
One of the big confusions is what is becquerel, what is
this.
I think we need to be more uniform on that, but anyway.
Yes. So fixed approach is 200 to 800 megabecquerel. Actually, I had that slide, but I deleted it for this. I thought it was too much. Limited personalization, as we said, per gram of thyroid tissue, 15 megabecquerel per gram thyroid tissue, and dosimetry, at least 300 megabecquerel for functional ablation. So either you give it per gram thyroid tissue, which is based on the ultrasound findings, or you give a dose which is high enough to cause complete ablation. So these are the various forms followed. Now, what about post-procedure? Usually 4 to 8 weeks, there is normalization of TFTs and improvement of symptoms. And beyond that, we see hypothyroidism. So in this phase, we taper the propranolol. Very important is you resume the ATDs. Usually what happens is these patients go home and they're told to stay at home and not interact with people. But if you advise them, you resume the drug after 1 to 2 days after ablation and then taper accordingly to prevent the risk of transient hyperthyroidism. And thyroid supplementation, of course, can be started based on the following FT4 reports. So usually what happens is initial 1 to 2 months, we don't see the patients for the first month because that patient needs to maintain distance. So after the first 2 months and the 6 months, what we have to do is we have to monitor the patient every 4 to 6 weekly, where we see the gland size, we see the TFTs, and see the clinical signs and symptoms of hypo or hyperthyroidism. What about retreatment? Retreatment, as per the ATA guidelines, is mentioned in 2 instances. If the hypothyroidism persists after 6 months, or there is minimal response even 3 months after therapy. So the one patient actually, sir, which she had discussed, was in 3 months. Yeah. So within 3 months only it was there. So RAI should be considered in this situation. This is a guideline by the American Thyroid Association specifically to the radiation therapy. So few points from here basically to keep in mind is the effective half-life of I-131 in a hypothyroid gland is about 5 days. And in hypothyroid patients who are given RAI, they retain greater radioactivity and they have higher levels of circulating radioiodinated thyroid hormones. So we need to be very careful and explain them step by step what they should do after this ablation therapy. Majority of the excretion of radioiodine is via urine, but also present in stool, saliva, and other bodily fluids. So very common question is, usually not in pediatric, but in the adolescent age group, which might seem, what happens if the pregnancy is detected after the RAI ablation? So is there an effect of fetus? So usually what it is mentioned in these guidelines is basically, hopefully this is a early pregnancy. So usually before 10 to 12 weeks where they do not know they're pregnant. So the organogenesis is still not started and the thyroid, the thyroid concentration in the fetal thyroid has still not begun. So hopefully that will not be affected.
Usually there will be a miscarriage.
Or miscarriage.
Such a higher radiation
might happen. But there is a concern for fetal whole body radiation exposure, so we need to monitor. There was no evidence found about infertility being caused by this, but it is seen that usually fertility occurs 1 year after this therapy. There has been a transient FSH elevation in men, and it might take around 18 months, and it might remain for 18 months, and due to a transient testicular dysfunction. What about the time and distance? So immediately after the radioactive iodine therapy, adult family members and caregivers should remain 6 feet away, except more than 25% of time at the first month. Now, patients should sleep alone and stay at least 6 feet away from other individuals during night time. There should be a separate bedroom or separate sleeping area, and hospital stays not advised. These are the guidelines mention also, like as and when the days increase, you can spend longer time with other individuals, but initially these guidelines should be followed. Post travel, a private car should be used. There is no limit or time distance in that, but if you're with another person, make sure you're in the different row, sitting behind the person who is driving. And public and mass transportation should be avoided. This again, as you see, as and when the days are improving, you get more time, more travel time, and also dosages are important in this. Coming to the important part, urine. Urine is the primary excretion route for iodine 131. It is the maximum excretion during the first 48 hours after treatment. So sufficient fluid, such as 3 to 4 liters per day, should be consumed to enable frequent urination. Men should sit down and pass urine, and the rim of the commode should be cleaned after the urine. Radioactive saliva can be contained in utensils, beverages, toothbrushes. If telephone mouthpieces are shared, they should also be wiped carefully after use. Blood from wounds, epistaxis, menstruation require special precautionary cleanup. Now, these guidelines are mentioned available online, and these are always presented to the patients, and they should follow this, especially when they're living in a close space with other individuals. One important bit is the complications of ablation. Now, there was always a risk of thyroid cancer from low-level exposure. However, it is found that with the ablative therapy, there is absolutely no risk in thyroid cancer. There was a risk of mortality after radioiodine. This risk was actually, it's an extrapolation from the Chernobyl incident, where we saw the radioactive might cause mortality. Of course, it is the complication we need, that is hypothyroidism. We are looking forward to that, so whether to cause it as a complication or not. And finally is the radiation thyroiditis, which might cause transient increase in thyroid hormones. And finally, orbitopathy and radioiodine, we know why it happens. So in mild active ophthalmopathy, it can be given with prednisolone at 0.4 to 0.5 mg per kg. Start 1 to 3 days after RA and continue for a month. But in moderate to severe, it is absolutely contraindicated.